Greetings from Indian Journal of Anaesthesia. I, Dr. Kiran Mahendru, will present an original article published in the September issue of IJA. The article is on enhancing the postoperative analgesia in carotid endarterectomy patients, the potential of ultrasound-guided carotid sheath block combined with superficial cervical plexus block, a randomized trial. Carotid artery stenosis is among the prominent causes of ischemic cerebral infarction. It is the second largest cause of death globally, therefore it is a healthcare burden. Carotid endarterectomy is advised as an optimal treatment option for asymptomatic patients with carotid stenosis of more than 60% and for patients who have experienced symptoms in the last 2 weeks. During the procedure, the carotid artery is cross-clamped, therefore it is crucial to assess the neurological function. Therefore, an awake patient undergoing regional anesthesia is the gold standard technique for these patients. Regional anesthesia has significantly fewer non-neurological, non-fatal, and cardiopulmonary complications. The cervical nerves C2 to C4 blockage is required to perform a block for carotid endarterectomy successfully. A superficial cervical plexus block alone or along with deep cervical plexus block must be performed. Carotid sheath block involves infiltrating the carotid sheath with a local anesthetic, targeting the upper radicle of the ansa cervicalis and the vagal nerve that innervates the sheath. It differs from the classical cervical plexus block, which does not anesthetize this area. Therefore, the hypothesis of this study was that ultrasound-guided carotid sheath block and superficial cervical plexus block will prolong the post-op pain alleviation in patients undergoing carotid endarterectomy. The primary objective was to examine the extent of sensory block after combining the carotid sheath block with the superficial cervical plexus block, and the secondary objectives were to examine the effectiveness of this combination in enhancing the quality of analgesia in postoperative recovery and to assess the occurrence of adverse complications. It is a randomized control study conducted between September 2022 to January 2023. It is registered with the Australian New Zealand Clinical Trials Registry. The patients included were those with critical stenosis of more than 70% of the carotid artery and ASA physical class of 2 and 3, and the patients with age more than 80 years, with hepatic dysfunction, severe malnutrition, allergies to local anesthetic, or BMI of more than 40 were excluded. All the patients were randomized into either of the two groups by random order through the sealed envelope technique for allocation concealment. The subject group, which included a total of 28 patients, received both superficial cervical plexus block along with ultrasound-guided carotid sheath block, and the control group, which included 31 patients, received only the superficial cervical plexus block. No pre-medication was given, and the procedure was performed 30 minutes before giving the surgical incision. Complete blood count was done, and the blood was drawn 2 times, 1 hour before and 6 hours after performing the block to establish the NLR, that is the neutrophil to lymphocyte ratio. Continuous arterial catheter-based invasive blood pressure monitoring was done in the radial artery, with data collection beginning at the initiation of the block and continuing until 2 hours post-surgery, and the values were recorded every 5 minutes. An independent study physician, unaffiliated with the operating room procedures, prepared the local anesthetic mixture and conducted the block administration as per the assigned group. The cervical plexus block was performed by an experienced attending anesthesiologist with more than a decade of experience in clinical practice. Now, for the superficial cervical plexus block, while the patient was lying down with the head oriented contralaterally, the subjects in the control group received superficial cervical plexus block following the skin disinfection, and a 25-gauge needle was inserted past the epidermis to approximately 1 centimeter in depth to deliver 15 ml of local anesthetic solution posterior to the sternocleidomastoid muscle. An in-plane ultrasound-guided technique was employed, and the remaining solution was given subcutaneously in the superior and inferior direction along the entirety of the dorsal side of the muscle, utilizing a needle fanning method. Subacute infiltration of local anesthetic was also done along the inferior margin of the mandible, at the suprasternal notch, and along the surgical incision region to attenuate the pain elicited by continual application of retractors and blocking the afferent branches from the diverse nerves. The blinded anesthesiologist within the operating room assessed the sensory block. For the carotid sheath block, ultrasound high frequency linear probe was positioned laterally at the cervical region, precisely at the mid section of the rear margin of the sternocleidomastoid muscle, ensuring that the muscle's posterior boundary was centrally depicted on the ultrasound screen. After the carotid artery was acknowledged, the needle was thrusted, traversing the cutaneous layer and platysma until its tip was set adjoining the carotid artery sheath. And a total of 10 ml of local anesthetic formulation was given circumferentially around the carotid artery. 0.5% of levopivacaine for a dose of 2 mg per kg and 2% of lidocaine for a maximum dose of 2 mg per kg was used as a local anesthetic. Numeric pain rating score was done to evaluate the pain by the on-call anesthetist who was unaware of the patient group assignment, and the assessment was done as 2, 4, 6, 8, 10, and 12 hours. The time when the block was given was taken to be time 0. Now, the patients who have a numeric pain rating score of 1 to 3 were given 1 gram of paracetamol IV. The patients with the pain scores between 4 to 6 were given 100 mg of tramadol. And the patients with pain score more than equal to 7 were given both paracetamol and tramadol. Pain scores and time of administration of analgesics were recorded. The primary outcome of the study was the sensory block length of time, defined as the span from administration of the block up to the notification of pain sensation in the surgical area with a pain score of more than equal to 1. The secondary outcomes were the start of the sensory block, that is, the period from finish of the local anesthetic injection to the achievement of loss of pain sensation, that is pinch. The time to request for additional analgesia, percentage of patients using opioid postoperatively at least once in the first 12 hours, and the quotient of absolute neutrophil count to absolute lymphocyte count, that is the NLR ratio from the peripheral blood. Possible complications and adverse effects of anesthesia were observed for 24 hours, which included hypotension, that is a systolic BP of less than 90, bradycardia, that is a heart rate of less than 60, nausea, vomiting, hematoma at the site of injection, and any signs of systemic local anesthetic toxicity, which included vertigo, tinnitus, disorientation, tremors, convulsions, respiratory depression, and cardiovascular instability. The sample size was calculated based on a previous research, and a total of 26 patients per group was sufficient. Analysis of variance Mann-Whitney U or log rank tests were used to analyze the distinction of selected variables. Total of 70 patients were assessed for eligibility and 60 were randomized. Out of these, 31 were analyzed in the subject group and 31 were analyzed in the control group and 28 were analyzed in the subject group. The patients were comparable when compared for the demographic and the baseline characteristics. Coming to the primary and secondary outcomes, there was a significant statistical disparity observed in the sensory block duration time, which favored the subject group, that is the patients, those who received both the carotid sheath block along with the superficial cervical plexus block. There was a significant reduction in the median sensory block onset time in the subject group. The interval of requirement for additional analgesia was also extended in the subject group. So the percentage of patients in the subject group that exhibited a numeric rating score of 0 in the first 12 hours was 42%, as opposed to 16% in the control group. Therefore, these outcomes were in favor of combination of carotid sheath block along with the superficial cervical plexus block. That is, the sensory block onset time, the total sensory block duration time was better in the subject group compared to the control group. The opioid use in the first 12 hours differed in the subject group from the control group. And in both the groups, the post-op pain scores were less than 5 throughout the tracking period of 12 consecutive hours. The hemodynamic variables were similar in both the groups. There was no statistically significant differences between the groups as per the various time points studied. Therefore, coming to the discussion part, the combination of the superficial cervical plexus block along with the ultrasound-guided carotid sheath block prolongs the duration of sensory block for carotid endarterectomy surgeries. The time to additional analgesia after the combination of block is also longer, and overall need for analgesia is less than superficial cervical plexus block alone. The hemodynamic stability did not differ between the two groups. The patient in the subject group experienced superior block quality, highlighting its efficacy in providing enhanced pain relief. The incidence of adverse effects did not show any meaningful distinction between the groups. Number of reviews or studies focus on comparing regional techniques in the cervical plexus block to reduce the block onset time. But as per the authors, the reduction in the block onset time is not attributed to the combination of blocks, but rather to the synergistic effects of combined drugs. The onset times were so brief that their significance was negligible. Initial NLR did not differ between the two groups, but there was a subsequent increase in the NLR ratio observed in the subject group at 6 hours time point. However, it was not statistically significant. This reflected that the procedural stress and the body stress response to surgery is affecting the NLR ratio rather than being influenced by the choice of the regional technique. The limitations of this study are a relatively limited sample size that would potentially impede its extrapolation to the results to a broader demographic cohorts, and the inability to conduct a patient follow-up beyond 12 hours represents a potential weakness in this investigation. To conclude, combined administration of superficial cervical plexus block with ultrasound-guided carotid sheath block effectively extends the post-op analgesia for patients undergoing carotid endarterectomy surgeries. Importantly, this combined approach has proven to be safe as it does not influence the occurrence of the adverse effects. Thank you so much.